Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAMS-AIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAMS-AIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The NAMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Good afternoon, one and all. I welcome you all to today's NAMS-AIIMS PGI Navigate the Online Medical CME program for postgraduates and young faculty. I would now like to request Professor Umesh Kapil Sir, the Honorable Secretary of the National Academy of Medical Sciences, to deliver his welcome address.
I think on behalf of Secretary NAMS, and it is my great privilege to welcome the distinguished speaker for this afternoon, Colonel Dr. Jia Kaushik ma'am. Thank you so much, madam, for being with us and giving us your time. I'm sure that based on your experience, the practical tips which you will give to our participant will be very, very useful. So thank you so much, madam, for being with us this morning. I also extend warm welcome to Major General J.K.S. Parihar sir, who has been the chief coordinator for this series on ophthalmology. Thank you, sir, for being with us and encouraging us with your presence. I also like to extend warm welcome to all the participants, faculty members, PG students, and other colleagues who have joined us this afternoon. And if you have any questions and queries, our expert will be happy to answer those questions. So kindly send your answer on the chat, questions on the chat box so that this can be answered. So once again, I welcome all of you for this session. Over to you, Dr. Preeti, please.
Thank you, sir. Now I'd like to request our IT team, Mr. Raviji, to display the message from our President NAMS, Dr. Digambar Behera, sir.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you, sir, for being a constant source of support for the Navigate Medico CME program. Now, I would like to request Mr. Raviji to display the message from the Honorable Director of the All India Institute of Medical Sciences, New Delhi, Mr. Srinivas, sir.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you, sir. It's now my honor and privilege to introduce the Chief Coordinator of the Ophthalmology Series for the NAMS Medico CME program, Major General J.K.S. Parihar, sir, who was a former additional DG AFMS of Medical Research, Health and Technology. Sir is also the Professor of Ophthalmology and Head Academics and Training, Center for Sight, New Delhi. Sir is a chair of multiple professional societies, including President iBank Association of India, President-elect IIRSI Intraocular Implant and Refractive Society, India, Vice President of ACOIN, Executive Team Member in Global Alliance of iBank Association, and Governing Council Member of Association of Asia iBanks of Asia. Sir has a vast teaching experience and has been a PhD guide, PG guide, and PG and UG examinership of 19 universities, including AIIMS New Delhi and NBE. Sir has multiple publications to his credit and multiple research to his credit. Sir has also won multiple awards, including the prestigious Sena Medal, Bar to Visist Seva Medal by the President of India, commendations of multiple societies, Republic of Afghanistan Appreciation Award 2016. Sir also has the Limca Book of World Record 2013 for performing phacoemulsification cataract surgery at the highest altitude in the world. Welcome to the CME program, sir. Over to you, sir.
Thank you very much, madam. On the outset, I am privileged and deeply indebted to National Academy of Medical Sciences, its present president, past presidents, my dear respected Professor Kapil and Professor Sood sir, for giving me this responsibility of coordinating and steering the CME program of specialty of ophthalmology. This is before that we have 3 lectures by eminent professors from FMC, All India Institute, and AIIMS Jodhpur. And I'm sure Colonel Jaya Kaushik, who is a renowned ophthalmologist and trained in the entry segment, will do justice to the topic, which is of very close to my heart and very, very important, the pediatric ocular trauma. So I welcome you all on this, all the participants, those who have taken time out and joined, and at the outset being it's a very auspicious day of Teachers' Day. I extend my wishes to my all students and my gratitude to my all mentors, elders, and teachers. Thank you very much.
Thank you, sir. Now I would like to welcome the speaker of today's session, Colonel Professor Jaya Kaushik ma'am, who is a professor in the Department of Ophthalmology at Armed Forces Medical College. Ma'am has multiple awards to her credit, including the Chief of Year Staff Award for the year 2016 to 17 in Surgery and Allied Services for the paper title Efficacy of Bevacizumab compared to mitomycin C modulated trabeculectomy in primary open-angle glaucoma, a 1-year prospective randomized controlled study during AFMRC conference. Ma'am has also been awarded in the Women Ophthalmologist Society for her contributions in cornea and has been identified as a member of the committee by PGIMER in the subject discipline of ophthalmology to develop standard treatment outflows. Ma'am has multiple publications to her credits and her special interests include scientific writing, landscaping, and gardening. It's a privilege to have you with us here, ma'am. Over to you, ma'am.
Sure. Come. Sure. Sure.
Am I audible?
Yes, ma'am.
Okay. So, good afternoon, everyone. At the very outset, I would like to thank and extend my gratitude to Dr. Sood, Dr. Behra, Professor Srinivasan, General Parihar sir, Dr. Umesh Kapil sir, for giving me an opportunity to deliver this lecture on this platform. Today being Teachers' Day, I would like to extend my warm wishes and gratitude to my teachers and also auspicious Onam and Eid. So a lot of celebrations today, and we would be discussing a very interesting topic today, tackling pediatric ocular trauma, which is, I would say, for residents, PG residents, it's important that we know how to manage this uh, topic or a clinical entity in day-to-day practice. The questions on a theory basis, it might not be a very important topic, but handling these kind of emergencies and pediatric ocular trauma is a big challenge for ophthalmologists, and PG trainee should definitely put an effort to know that what is basic things which are required for them to know. So I'll be covering my topic in following heads: the importance and challenges, epidemiology, classification, etiology, examination, imaging in ocular trauma, chemical injury, blood trauma, open globe injuries, traumatic glaucoma in pediatric age group, sympathetic ophthalmia, psychological aspects, preventive measures, and conclusion. So, as we know that the trauma in pediatric age group is the significant cause of acquired unilateral blindness and morbidity. It ranges from a minor scratch to a severe sight-threatening condition, and to a very surprising fact that 90% of these trauma can be preventable, and if the prompt management is given, it may minimize the lifelong visual disability. Pediatric ocular trauma is not only associated with the ocular injuries, it has associated emotional stress to the child and his parents. It requires frequent visits, and it involves the economical burden to the society. What are the challenges encountered in management? When we say that a child comes to the casualty, it has multifactorial challenges. The atypical or a subtle presentation, because of elastic sclera, which may mask the serious internal damages. Then there is always a diagnostic delay, as children sometimes cannot even articulate their problems. Difficult examination, that children are usually
Excuse me, ma'am.
yes.
Ma'am, actually the slides are not changing and it is not in the slideshow mode.
No, I am on the second slide: challenges encountered in management.
Ma'am, if you can put it in the slideshow mode, we'll be able to see.
Can you see now?
No, ma'am. Actually, it is not in the slideshow mode. I'm able to see this fourth slide now.
No, I have. See, this is my first slide, second slide, third after importance. Now it is challenges encountered in
Yes, ma'am.
management.
Now it is changing. Now it is
Yes.
changing. Yeah.
So if I will start now, is it fine?
Now it is in the fourth slide, ma'am. Yes, ma'am.
Okay, fine. So the examination is difficult in this pediatric age group because of the smaller anatomical structure. Diagnosis is difficult, surgical repair is also difficult, and usually there is greater risk of secondary complications and higher risk of amblyopia and psychological impact in these children. I hope the slides are changing. Okay.
Again, it is still in the fourth slide.
Able to see the movement of the slide.
Sorry?
I am able to see the slides are moving.
Yeah. Yeah.
Yes, now it is moving, ma'am. Now it's in the fifth slide.
So why children are more at the risk of ocular injury? Because of their peculiar, curious, active, and exploratory behavior. They are always risk taking. They are not scared. Lack of fear is there in these children. They have lack of protective reflexes, and because of absence of supervision and unsafe play environment at home or at the playground. A study done by Dr. Boret in French cohort revealed that most of the ocular trauma, the age group is Maximum age group is between 10 to 15 years, accounts for almost 41% of the incidences. Overall, 5 to 15%, 5 to 15 age group has maximum chances of ocular trauma. Similar studies was done by Dr. Moria et al. And it was seen in India, and it was seen that the most vulnerable age group was 6 to 15 years of age. Males were more predisposed, and the maximum children belong to rural background.
Excuse me, ma'am, slides are not moving. We have to put in a slide show mode, then they will move.
Is it moving now?
We have to, yes, now it is there. But
So
you
do
have
I
to,
present like this?
yes,
Do
yes,
I
you have to,
present like this only? It
yes,
is
yes,
moving
no
like that.
problem. Yes,
Okay.
fine.
So in India, the same incidence group was incidences were seen in the pediatric age group. Another interesting finding was what Dr. Boret had uh, observed in her study was that the place of injury was at home. So most of the injuries, approximately 50%, occurred during the at the home domestic accident, followed by the public area and school injuries and traffic. Similar findings were also studied by Dr. Singh in in the in central India, that the home was the place where maximum of such injuries occurred in a pediatric age group. So broadly, if we classify, the classification of injuries are same. The trauma classification is same like adults or the pediatric age group. Mainly broadly divides into mechanical injuries, that is into open globe, closed globe, orbital wall fractures and adnexal injuries, and non-mechanical injuries, which includes chemical, radiational, electrical, and many other non-mechanical causes. So, as per the Betts classification, the closed globe injuries are classified into contusions and lamellar laceration. Open globe injuries are classified into laceration, further into the penetrating, perforating, and intraocular foreign body. And the another open globe type is the rupture. So, as the another way of classification of open globe injury and closed globe injury, as per the American Journal of Ophthalmic Society, it is like we classify into type, grade, pupillary reaction, and the zone. So, in cases of open globe, it is if it is ABCD based on the rupture, penetrating, intraocular foreign body, perforating, and the mixed one. Grade would be based on the visual acuity, pupil positive or the negative RAPDs, and zone, the part of the zone 1, 2, 3, based on the what part. Zone 1 is isolated up to the cornea, including the corneal scleral limbus. Zone 2 would be corneal scleral limbus to a 0.5 millimeter posterior into the sclera, and zone 3 will be posterior to the anterior 5 millimeter of the sclera. Closed globe injury will be also classified in type A, B, C, D, contusion, lamellar laceration, superficial foreign body, and the mixed variety. So again, further it will be based on the grade of visual acuity, pupil, positive and negative RAPD, and the zone external up to the conjunctiva, sclera, and cornea. Then anterior segment, it is like a normal adult classification. These injuries are same. So, what are the etiology? Most common etiology is the blunt force. The maximum children present with the falling trauma with history of blunt force. Then projectile injury, penetrating explosion, chemical, and the crush injury. As you see in these pictures, that the fingernail cracker, siblings fight with the siblings, gully danda. These are the very common causes of pediatric ocular trauma in Indian scenario. So what makes it different from adult ocular trauma? Pediatric ocular trauma versus adult ocular trauma, there are few challenges which makes it different. The mode of injuries, evaluation challenges, management protocols, and long-term outcome. Study which was done by Dr. Satyendra Singh and published in IGO in 2017, it gave a very interesting fact that most of the injuries which were caused by in the pediatric age group were by the organic matters like stick, wheat twigs, gully danda, approximately 65%. And in open globe injuries, the penetrating injuries are most common. And in closed globe injuries, contusions were very common. So these were the findings which were found in a tertiary eye care center within the central India. So how we go about the examination of a child who comes to the casualty with history of trauma. So first of all, there are challenges. Whenever a child comes to MI room, there is usually a poor history. Parents are in panic, child is very scared. So poor cooperation by the parents, poor cooperation by the child. So assessment could be challenging, may need general anesthesia to assess the complete damages and trauma. And there is always an impact on the emotional and social development of the child and risk of amblyopia if the child is less than 7 years of the age. How we go about the ophthalmic examination, the detailed history is important, mechanism and circumstances of the injury, whether it is a sharp or blunt object or the size of object. Exact time of the injury and place of injury is also important. These all things will eventually affect the outcome and post trauma visual recovery. Prior ocular history, pre-injury vision status, or it is very important to examine the non-involved eye. How we start is firstly we have to see the status of the child beside eye, any other injuries he is having. Around the eye, we start with the external examination of scalp, face, periorbital soft tissues. Palpation and examination, clinical examination is important. Then we see the lid and for any laceration, periorbital edema, any foreign body, visual acuity at the time of presentation. If child can, tell if it is he is very small, it becomes difficult. But uh, any age group where he can tell the visual acuity is it reflects the outcome post trauma. Pupillary reaction and extraocular motility. So relevant findings to be examined, to be looked for with the pediatric age group on the slit lamp examination. Again, it is very important that whether child allows in examination or not. It is very difficult. I have seen encountered so many children with ocular trauma. They initially just refuse to sit on slit lamp examination, even if sometimes the torch examination becomes so difficult because these children don't open the eye. So, okay, am I visible? Are the slides visible?
Yes, ma'am.
Okay, fine. So imaging has okay. So we need to see conjunctiva for we have to look for chemosis, hemorrhagic chemosis, foreign body, or the subconjunctival spaces for any kind of foreign body, upper or lower subconjunctival space. In cornea, epithelial defects, abrasion, intracorneal foreign bodies. Siddle test is important if we want to confirm the wound leak in cases of partial or full thickness lacerations. Then sclera, sometimes it is very difficult to see any scleral rupture because occult, it may be occult rupture or posterior rupture. Anterior chamber, if we can visualize for cell, fibrin, hyphema and hypopyon or any intraocular foreign body. Iris and angle, very difficult. Iris can be seen still, but angle examination becomes difficult in a pediatric age group. and lens for any subluxation, dislocation, or if possible, if we can see the fundus examination, that will also help in the future management. So imaging is very important in ocular trauma, and especially pediatric age group where examination become very difficult. But again, the age group matters, whether we require sedation or under, uh, because if child is uncooperative, he will not allow to do get X-ray done or the CT scan done. Plain X-ray is important to know the shape and number of metallic foreign body or any bony injury to the orbit. CT scan is very important modality of choice in any type of ocular trauma, whether it is pediatric age group or the adult. It helps to diagnose the occult globe rupture. It may detect intraocular foreign body and any kind of retrobulbar hemorrhages or orbital wall fractures can be seen. B scan, ultrasound B scan can be done to in cases of blunt trauma where we are suspecting the vitreous hemorrhage or retinal detachment. In open globe injury, B scan cannot be done. UBM aids in localization or removal of the small intraocular foreign body, especially when they are stuck in the anterior segment of the eye. MRI cannot be done if we are suspecting a metallic foreign body. So chemical injuries in pediatric age group is very common. We come across so many cases in day-to-day practice, especially in rural background when children are being brought to the MI room by their parents with history of chemical injury. This was a patient, child 2 years old, was brought by his parents with excruciating pain in his right eye. He was left alone playing near the storeroom where he accidentally spilled unwrapped potassium permanganate crystal bag into the eyes. You can see these crystals and child presented with severe pain. That management include copious eye irrigation with normal saline was immediately performed until pH neutralization. If we don't have litmus paper to check the pH, then we can at least perform water irrigation for 30 minutes. Then subsequently, child was treated with topical antibiotic, steroids, and copious lubricants, and vitamin C. The Procera was applied for improving the epithelialization and prevention of symblepharon. After 6 to 7 months, child had clear cornea with almost 6/6 vision. Another patient which we very commonly encounter is hand sanitizer induced chemical injury or the washroom toiletries, drainage or harpic or tuna lime. These injuries are very common in India, especially in rural background. The treatment remains same, that eye should be um, washed thoroughly at least 30 minutes. So management of chemical injuries in pediatric age group, the child will present with immediate intense conjunctivitis and chemosis. He will not allow you to open and examine his eyes. So the first of all, we can put some paracaine, some local anesthetics to improve the to reduce the pain and by which child allows you to examine, and then there should be immediate copious irrigation of normal saline or BSS to remove excess of uh, deleterious material at the earliest. That is a thing which will prevent maximum damage to the eye. An IV infusion line or 20 ml syringe can be used to clean the phonesis, and continuous flow of saline into the ocular surface should be done. All phonesis, upper and lower, should be thoroughly washed and continued till pH returns to normal. So for subsequent to this, we should pick up the particles of limes or any chemical which should be picked up with a forceps or after installation of the local anesthetist, antibiotic ointment and cycloplegics to be avoided. Steroid also to be prescribed for at least 10 to 2 weeks. Vitamin C is given topically, and prevention of Simplifron should be done by gently putting the Johnson bud or a glass rod along the fornices, and fitting of BCL may be required. Uh, all these things are done to prevent the limbal stem cell. Subsequently, if required, limbal stem transplant or amniotic graft can be performed in these children. For pediatric age group presenting with blood trauma, we have similar kind of presentation, but most common are blowout fracture of medial wall or the floor or orbital hematoma, the eyelid hematoma or avulsion of the lower lid, or conjunctival hemorrhages. The cornea may, in anterior segment, children may present with abrasions, which are very common with the uh, siblings, nails, or while playing, they might injure with the. I have seen so many ocular injuries with the pets nails, dogs or cats. So that is a very common of corneal abrasions. Um then children may present with hyphema, iridodylisis, or the angle recession. Another injuries following to blunt trauma may be cataractus lens subluxation, rupture of anterior posterior capsule of the lenses. In sclera, child may present with the rupture, which is most commonly at the limbus or behind the insertion of the rectus muscles. In posterior segment, children may have blunt trauma, usually may be associated with vitreous hemorrhage, so retinal or subretinal hemorrhages, retinal dialysis, or retinal detachment or macular edema. So, how to manage the open globe injuries in pediatric age group? This is one of the most commonly seen injuries and very difficult to manage in pediatric age group. So, um, the case which I will be discussing is a 7 years old son of a serving soldier who sustained injury to right eye accidentally by the knife while playing. He presented with persistent complaints of pain and diminution of vision. The presentation was like this: that there was a poor vision of 160. There was a large corneal laceration. Eye was soft, and pupil was irregular and sluggishly reacting to light. The extraocular, the it was very difficult to examine the child because child was in pain. The patient had open globe injury with corneal laceration and iris tissue, prolapse, and traumatic cataract. So what we planned was that for such patient, the primary goal is firstly under IV antibiotic cover and under GA. Primary globe repair is the key treatment first and foremost. We should we should do the wound exploration followed by intraocular tissue reposition, cataract. After making a corneal suturing, the cataract lens can be removed, and primary repair, we should leave the patient aphakic, and subsequently secondary IOL can be planned. Another case of child which presented to us, it's again very common uh, cause of trauma which we see day to day in day to day practice is pencil tip injury. Child presented with a open globe with ruptured anterior capsule and irregular pupil, shallow AC. So first day we immediately plan to do the primary repair, but child had very poor vision uh, because the lens capsule was ruptured, as you can see here, and there was total there was total lens matter inside the anterior chamber and on the endothelium. So we decided to do second day the cataract lens intervention, and on table we saw that there was PCR. In such cases, it is required that we should do a nice good vitrectomy to clean all the vitreous inside the anterior chamber. We can use triamcinolone to stain the residual vitreous. After vitrectomy, we saw when there is a remnant residual bag, we had put 3-piece foldable hydrophobic acrylic IOL, and patient improved to 618 after 6 weeks of surgery as with the well centered IOL, because thankfully the corneal suture were away from the pupillary axis. In cases of suspected globe rupture, there would be a bullous subconjunctival hemorrhage, irregular pupil, uveal prolapse, and hyphema, and the low IOP. We need to be extremely cautious to while examining these patients to avoid extrusion of the intraocular content, and while transferring these patients to a VR facility, we should be very careful that we should shield the eye. We should not patch or do any pressure on these patients. So the principle of surgical repair in such patients, the primary objective remains complete watertight closure of the globe. I repeat, complete watertight closure of the globe, along with restoration of the structural integrity should be our primary goal. The secondary goals are removal of the disrupted the cataractous lens or the vitreous in the AC, and removal of intraocular foreign body. So these things can be taken as a secondary surgical measurements. In cases of non-penetrating partial thickness corneal laceration, if the laceration is partial thickness and a very small, it can be healed with the topical antibiotic cycloplegic, and BCL can be applied, and if it is deeper we can do the suturing also. Simple full thickness, very small laceration less than 3 millimeter in size, small self-sealing corneal perforation, we can apply BCL, and it can be left for 3 to 6 weeks, and it leads to healing. So another thing is, in case there is a very small full thickness less than 2 millimeter size, cyanoacrylic tissue adhesive can be applied to for healing these small full thickness corneal perforations. If the laceration corneal laceration are large, more than 2 to 3 millimeter, these are displaced wounds with loss of corneal tissues, or with the in iris or lens incarceration. The ultimate goal for corneal suturing should be to make the wound should be watertight, minimize the scarring, and to reconstruct the native non-astigmatic corneal contour as much as possible. 10-0 ethylone monofilament nylon 10-0 suture is the most perfect suture for the corneal suturing. We should always remember that initially placed suture may need to be replaced as subsequent suture may loosen them, and the suture length should be at least 1.5 millimeter long and 90% depth. Avoid avoid piercing into the descemet membrane, so that we do not compromise the endothelium. So in case when there is a corneal laceration with iris incarceration, we should, if it is healthy appearing prolapsed iris, it should be repositioned back with conscious. If the iris is devitalized, it is extremely macerated, feathery and depigmented, then prolapsed iris should be excised. And the goal is to preserve as much as tissue as much as possible to maintain the iris diaphragm. corneal, when there is a corneal involvement with lens, when the lens is affected in these, we should see that if surgical field is clear, we should preferable to complete all operative intervention at one session. If there is poor visualization through the cornea is edematous, we should just close the laceration cornea part and lens can be tackled later. So that is the most important thing. First we have to maintain the structural integrity and lens can be handled later. So the rules of pediatric cataract surgery in cases of trauma remains almost same, but these cases are little difficult to manage as there is already a traumatized eye, and whether the age will what age child comes will depend whether we are going to put IOL or not. So the rules will remain same. Regarding placement of the IOLs, we have to see that moment what child has presented, and if he has a developed uh, corneal diameter more than 10 millimeter, normal IOP, any absent angle anomaly, and his axial length is more than 16, there is no vitreous in the AC, it is a clear cornea, then at the same setting we may plan to do the IOL placement also along with the along with the posterior capsulorhexis and anterior vitrectomy for the pediatric age group. The challenge comes in managing these cases with the amblyopia management. So we remember that these patients should be managed for till they acquire adolescence age. The initial up to 10 to 11, we should try to treat for consider the possibility of occlusion for amblyopia. So occlusion therapy of the sound eye, spectacle for children more than 4 months of age, and bifocals are very important post cataract surgeries in these patients. So if there is a corneal laceration with vitreous involvement, once vitreous comes into the anterior segment or in the when vitreous is disturbed, then it leads to many complications such as chronic inflammation, corneal endothelial damage, CME, vitreous fibrosis, retinal detachment, or infection. So primary goal of surgery is to relieve any vitreous incarceration in the traumatic surgical wounds, and we should do a vitrectomy to clear any vitreous which is prolapsing through the scleral wound or through the anterior segment. We should do nice and good vitrectomy because as we leave the vitreous, it leads to further complications. Next is these children are more common to traumatic glaucoma. Why? Because if there is lot of injury, there is a hyphema. So these children may lead to blunt trauma, sports related injury. These pediatric age ocular trauma may present with traumatic glaucoma subsequently. The risk factor may be advancing age, lens associated lens injury, persistent anterior chamber inflammation, penetrating ocular injuries, poor baseline visual acuity, vitreous hemorrhage, or intraocular foreign body. So, how this glaucoma occurs? It is blunt trauma to the eyeball, leading to tear in the ciliary phase and clogging of TM by clots, inflammatory cells, RBC leading to pupillary block and elevation of IOP and secondary glaucoma. These are the picture of rosette cataract and persistent hyphema leading to traumatic secondary glaucoma. So that if there is angle recession, the uh, the glaucoma may occur after years. In the and the diagnosis is gonioscopy based diagnosis. In children, it is very difficult. So I would like to reinforce on this aspect that whenever there is a pediatric age group, if we have to remove sutures, first EUA, subsequently the surgery, primary surgery, then if we have to take out the sutures or do the post-op refraction, in small children, you have to expose the child for repeated general anesthesia. So we need to be very, very careful ki how many times we are going to expose that child to the general anesthesia. So if possible, the suture removal can be accompanied with the gonioscopy examination. And if we find that there is a angle recession glaucoma, then the obviously that we start primarily with the anti-glaucoma drugs, but it is known that in pediatric age group, the drugs actually are not very effective if there is angle dissection, and we have to finally go for trabeculectomy or the GDD, glaucoma drainage implant surgeries. Why again I am discussing about these factors. Now I'm coming specific to the pediatric age group. Some problems like sympathetic ophthalmia, it is noted by Hippocrates almost more than 2 millennia ago. It is reported as the disease that places the normal other eye in great danger. uh, the sympathetic ophthalmia is a condition which is due to how it occurs. It may follow penetrating injuries, which leads to higher risk of developing sympathetic ophthalmia. It may appear anytime between first week of the injury to up to 60 to 70 years post injury, and it has seen that majority of such cases occurs within first year of time span, and there is no age or sex or race predilection. So this is related to the exaggerated immune response and type 1 T helper cell mediated delayed hypersensitivity reaction, which leads to bilateral panuveitis. The clinical pathologic features are Dalen-Fuchs nodules, uveal thickening in the uvea, which you can see on the uh, various examination. The onset of symptoms are acute or insidious. Age may be between 8 to 14 years. Children may present with that. The patient may present with conjunctival injection, granulomatous AC reaction, mutton fat capes, poorly responsive pupil, and posterior synechia. Fundus may, on retina, you may find the fundus may have vitritis, papillitis, and the choroidal lesions, Dalen-Fuchs lesion. Exudative RD may also be present. So this is the earliest symptoms present with the difficulty to see the near objects that decrease because of decreased accommodation. IOP may be elevated because of secondary inflammation or may be lower because of ciliary bodies shut down. How to investigate these cases is that we follow the normal routine by doing USGV scan, fluorescent angiography, ICGA, and SDOCT. These children require um, treatment with oral corticosteroid for a long duration, or in severe cases, we have to give IMBP pulse therapy with intravenous methylprednisolone for 3 days and subsequently oral steroid. Subtenon injection of triamcinolone can also be considered. Intravitreal steroid implant can also be given along with topical steroid cycloplegic drugs for treating these cases. The second line drugs are immunosuppressant, used immunomodulator, which can be used to prevent sympathetic ophthalmia or to treat sympathetic ophthalmia. Uh, Discussing about the topic on pediatric trauma. Here we encounter not only the children, we are encountering managing the parents also. So this aspect I would like to again reiterate that psychological aspect of pediatric ocular trauma is a very important thing. We are not only managing the children, we are managing their parents also. So it why does childhood trauma needs special attention? Because the most pediatric ocular injuries are taking place between 2 to 6 years of age, which is vital period for development of the visual system and development of the amblyopia. It is accepting eye injury is not only for the children, it is for a serious process for both child and the parents, and it affects the academic, social, physical and mental growth of that child. So why psychological aspect of childhood ocular trauma is less familiar or talked about among all of us? Whenever you are as a PG student, you are managing a child, please remember that it is not only child, you are handling two people. The psychomorbidity following ocular trauma in pediatric age group is usually ignored, and emotional reaction to these traumas have received very less attention in the textbook, and we should be always very empathetic and compassionate to these parents and the pediatric patients. These why they come with the traumatic stress post ocular trauma, because it impairs day to day functioning, it affects adherence to the medical treatment and and it affects their optimal recovery. And what are the symptoms they come with? They get easily upset or angry, they feel anxious, jumpy or confused, and being irritable and uncooperative. They lag behind in their class in learning and classroom teaching. They feel empty or numb. So these are the major psychiatric disorders which are normally seen in cases of trauma, but also in ocular trauma, PTSD, depression or anxiety disorders. So whenever any child comes, uh, what kind of psychological response we expect following the ocular trauma? Because of there is sudden decrease in visual acuity, the child is being at hospital or at home for long time after trauma. He is not able to attend the classes. He undergoes recurrent surgeries and multiple follow-ups, being separated from his parents while being operated, poor quality of life when compared to his peers at the school, all these changes in his physical appearance following eye trauma. So there is anxiety, sleep, conduct, learning and attention problem, impaired cognition, mood change, number of emotional reactions, intense feeling of fear and significant distress. Assessment and treatment of traumatic stress reaction. This is a topic which is usually discussed by the pediatric psychologist. So how would what preventive measures? This is the most important thing we should be teaching in the schools, or as a parents inside the home, we should teach our children that as a parents also we must at home we should keep sharp objects out of the reach of small children. Avoid whenever we are buying any projectile any toys, we should prevent buying avoid buying projectile toys. We should store household chemicals safely away from the reach of the small children, and supervised use of crayons, pencils and the art supplies. At schools there should be safety protocols during science experiments, monitor and guide safe place, supervise younger children actively to inspect equipment regularly, and mandatory use of protective eyewear while they are doing any science research or playing some uh, uh, doing things like which may damage the eye. At community level, parental and caregiver education about ocular trauma risk and first aid is important. So, point to note after my presentation, carry home message to all the PG students are that it is a preventable cause of lifelong visual disability. It not only affects the child, it really affects the entire house where a child gets ocular trauma. Both his parents get affected. Early recognition and timely tailored intervention are critical to preserve vision and ocular structure. Surgical management must balance anatomical repair with long term visual rehabilitation. Parental counseling and follow up are important, key in managing amblyopia risk and psychological impact. Preventive strategies at home, school, and community level are essential to reduce incidence. So, with this, I would like to thank my teachers and the organizing committee, Dr. Su, Dr. Behra sir, Professor Srinivasan, General Parihar sir, Dr. Umesh, for giving me opportunity to speak on this very important topic.
Over to you, Dr. Preeti.
Hello.
वो क्वेश्चन आंसर शुरू कर दीजिए प्लीज। अच्छा, आप फिर ऊपर आ जाइए।
Yes, sir. Thank you. Request the audience to put their questions in chat or raise your hands if you have to ask any questions. There are no questions in chat as of now. I think if there are no questions, ma'am, would you like to give some take-home points which you want the students to remember?
I would like, Dr. Preeti, I would like to convey to all the young ophthalmologists that while handling pediatric age group ocular trauma, we must be very careful since beginning. Like the day initial treatment is very important. Child will try his best not to show us the clinical examination, clinical signs would be very difficult to elicit. So a thorough EUA under GA, general anesthesia, is very important. For taking any child to general anesthesia also, it's just not like easy that day. So if somebody is sitting in a primary institute, primary eye healthcare center, we should be that doctor should know that he should be very gentle in handling the pediatric age group patients with ocular trauma at the initial presentation. He should not do any unnecessary force or pressure over the eyes, because it may lead, if there is a open globe, it may lead to further expulsion of the intraocular content. So the examination should be extremely gentle, and he should try his best that if he is not having ophthalmologist in a primary setup not having enough facilities, he should be giving him the antibiotics, IV antibiotics, and do the patch bandage and refer him to the further center appropriate for the appropriate management. But if he has facilities of primary repair, so the primary repair in these children is a goal, primary goal, and it really can, if there is an perforating injury, it really can affect the outcome, because if it is done nicely, the suturing is done beautifully, it may really restore the vision, and child may become visually, I would say, not crippled in later stage if he is managed properly in the initial stages. If the child is left untreated, there may be risk of infection, risk of intraocular content expulsion, and there may be endophthalmitis. So the primary treatment is very important in these cases, initial treatment.
Thank you very much, ma'am. It was a very informative webinar. I learned a lot from the same. Now I'd like to request Professor Ajay Sood sir to deliver the vote of address.
Okay, thank you, Dr. Preeti. On behalf of the National Academy of Medical Sciences, it is indeed my great privilege and pleasure to thank the distinguished speaker for this afternoon. Ma'am has really covered this topic in a very simple and especially the way you have shown the case studies. I think this is very, very useful to us, especially our PG student. So thank you so much, madam, and we look forward for your support and blessing in future also. I also take this opportunity to once again thank Major General J.K.S. Parihar, sir, who has been the chief coordinator, and sir has identified the best topic and the best speaker. So we really appreciate, sir, your efforts and support to the National Academy. I again like to thank all the faculty members from various institutions who have been supporting this program. It is your own program and you always are welcome to come forward and take sessions. Especially to the PG students, the next session in ophthalmology series is due on 3rd of October, where Major General J.K.S. Parihar will discuss about how the eye bank services is involved and about eye donation. So that is again going to be very, very interesting session. So please inform your colleagues in ophthalmology to join that. And all these recordings are available on our NAMS website. So you can download the videos and you can again go through them again and again if some concepts are not clear. Other information for our PG student is that NAMS, in collaboration with Indian Council of Medical Research, has started biostatistical helpline. It is online helpline. So we have given the details in the chat box, and details are also available on the website of ICMR as well as on NAMS. So if you have any difficulties in your thesis related to sample size, data, and all these things, our expert from NAMS and ICMR will be happy to help you. Another information is that Triple IIT Hyderabad and NAMS has started online 12 weeks program on artificial intelligence for health professionals. So especially those PG students who are technology savvy and our young faculty member, it is again a 12 weeks online program. And the second session batch is continuing. And you can always look into the website, our website or Triple IIT Hyderabad website, and you can enroll for that. The next session in the series is on 19th of September, where we have an expert from PGI Chandigarh, Dr. Vishal. Is going to discuss on inflammatory bowel syndrome. So please take note of it. If you have any questions related to this topic, you can share your question and we'll request the speaker to talk about that. I will also like to thank Dr. Preeti, who has been helping us from the very beginning, for being with us and moderating this session, and also the support which you have been providing to the academy. We are really grateful to you, Dr. Preeti, for your support to the academy. I would like to place on record the help which we have been getting from our IT team under Mr. Ravi, who is the IT officer at NAMS, and Mr. Shivam, who has been organizing this session on Zoom as well as on YouTube, and they are placing all these recording on our website. So thank you so much. Once again, I thank you all for being with us and wishing you happy Onam, Eid Mubarak, and we also remember our great teachers who have made us what we are on Teachers' Day. Thank you so much once again. Over to you, Dr. Preet.
Thank you so much. Thank you.
I declare today's academic session closed.